Hello, welcome to Ask Dr. Mingle, the Q&A series for Mingle Health, answering your questions about the quality programs and transition to value-based care. I am Dr. Mingle, founder and CEO of Mingle Health. Joining us today is one of the leaders of our client service team at Mingle Health, Brigid Whitney-Gallagher. She will help us to understand the optimum annual rhythm of quality reporting and how to get the most out of your client services consultant at Mingle Health. Good morning, Brigid.
Hi, Dr. Mingle.
Bridget, for the quality payment program, that is the QPP in 2025, I think this sorts into discussions of MIPS, that is the Merit-Based Incentive Payment System, MVPs, that it's MIPS Value Pathways, and APP Plus, the new expanded APM Performance Pathway for the Medicare Shared Savings Program, that is MSSP.
Absolutely. Although all three of these reporting pathways have their own nuances and requirements, they are all part of QPP, which is the Quality Payment Program.
Thank you, Bridget. Let's get started with the release of the final rule for MIPS 2025. What do you see as the most significant changes affecting the MIPS clients you and your team work with?
For MIPS, lots of things have stayed the same. The performance threshold, that is the amount of points to avoid a MIPS penalty, has stayed at 75 points. The data completeness threshold, that is how many patients and encounters you have to report on, has stayed at 75%. The performance threshold at 75 is through 2025 performance year. CMS has said that data completeness threshold, that is how many patients to report on, will stay at 75% through 2028. So they've projected that out into the future. In the cost category, there have been some scoring changes for the better, in my opinion. The curve has been skewed upward to line up with the medium cost. So excepting if you're on one far end or the other of the scale, the cost performance, how you perform in the cost category, will earn you more points than it has in previous years. So it's less likely that cost will drag down your entire MIPS score. This is great. Lots of practices have struggled with cost, with predicting cost and understanding how to impact it. So with the way they've shifted these scoring requirements, the cost category will be less of a burden as far as points as it has been. Improvement activities, which is another one of the categories in MIPS, there have been some changes there. So previously, improvement activities had high-weighted and medium-weighted activities, and practices had to choose different amounts of different activities. They've really simplified it in a really lovely way. So for traditional MIPS, you have to report 2 activities. If you are a small practice or non-patient facing, or in doing an MVP, you report 1 activity. So we don't need to concern ourselves on high-weighted, medium-weighted, any of that moving forward into 2025. I think that will really help the improvement activities category be more approachable for some practices. Oh, there also is a new extreme and uncontrollable circumstance application category. So after your submission, you would now be able to file an extreme and uncontrollable circumstance hardship if you have experienced vendor issues that have affected your submission. So if you were under contract with someone and they didn't make a submission or made a submission that was incorrect or some other issue, you would be able to address that with CMS so that you don't have to experience any penalty or negative ramifications based on a vendor issue. So that, I think, is a great way for CMS to support the practices and the providers while still acknowledging that, we do want folks to report, but we want it to be reporting in a way that makes sense and is going to be accurate.
Thank you, Bridget. Those all do seem very important to our clients. Let's just back off a moment to that whole MIPS, that annual recurring MIPS project. It seems that there may be an annual rhythm to MIPS quality reporting. What does that rhythm look like to you and your team, who's constantly talking to the MIPS participants out there?
You are absolutely right. MIPS, reporting MIPS is a cycle, and it follows about a 15-month calendar. So we usually break this up into quarters, quarter 1, 2, 3, 4, and 5. Our goal or our project plan, your way to optimize your best results working with us, is to really get started in quarter 1. So quarter 1 would be January, February, March of 2025. We want to make sure that your 24 submission or exemption, if that applies to you, is already resolved. So we want to make sure that's taken care of and buttoned up. And then we want to immediately jump to 25. So there are lots of things that need an early start. For example, there are new measures and improvement activities that are arriving every year. Measures, improvement activities also retire. So we want to see if measures you've reported previously are still available, if there are new measures that are a better fit. We also want to think about what is going to make sense for your practice this year. It's can be easy to kind of fall into a habit of, oh, we're doing the same thing we did last year, do the same thing we did last year. Lots of times that's okay. It doesn't mean it's the best option, though. So I really think it is important to, in the first quarter, take some time, think about how you need reporting to go this year, both in terms of group or individual, MIPS, MVP, technical changes, switching EHRs, a new billing company, new measures, new improvement activities. There are lots of things that at least need to be considered. One of the things that can happen is you can get into a habit, get into a way of doing things and not realize that over the years, the measures and activities change, and there might be better, easier options that more closely align with the care you're giving. So it's really worthwhile to kind of have what we call a kickoff call, which is essentially like, let's start the project. What are your goals? Who is at play? What challenges do you see coming up? And how can we make MIPS reporting meaningful and hopefully as least burdensome as possible? It really applies to all the different categories. Quality, we want to start as early as possible doing those quality metrics and making sure the documentation is in place. For promoting interoperability, that requirement is 180 days. So we are no longer in the days of starting your PI reporting in September and getting points. That's absolutely not the case. We need to have a plan early and make sure that some of those requirements, participating in clinical registries, making sure your certifications are updated, making sure that your dashboards are turned on in your EHRs, all of those things take time. And with the reporting requirement of 180 days, if you're starting middle or third quarter, we're already missing the timeframes we need for that. Another reason to get started early is for the cost category. We know that the shifting of the way that cost is scored will be beneficial to most practices. And lots of times cost can feel like a big kind of unwieldy category. Maybe you feel like you're in the dark or you don't have the information you need. We get it. We have a lot of containment strategies, mitigation strategies. CMS has started producing some patient-level reports that can be really helpful in practices investigating where they're doing well or not doing well in the cost category. So the sooner we get started on understanding what we're dealing with and understanding what the plan is for the year, the better off we're going to be with the project and the better you're going to score. So really, quarter one is the planning and review timeframe. Moving into quarter two is really all about two things: implementation and validation. So this is where we're saying, okay, send us what you have. Send us your billing data. Let's look at your PI dashboard. Let's see, what are we dealing with? Kind of what's the state of the state, if you will. And then we want to say, what trends are we seeing? Where are there possible vulnerabilities or concerns? And how can we address them? And so quarter two is really all about doing some deep dives. We want to do some deep dives into the data, make sure we're receiving all the billing data we expected, making sure if you're going to send us clinical files or if you're trying to use QDC, quality data codes, that all of those things are in place. Also, quarter two is really where we should be discussing what an audit would look like for you. This is one of those things that, it's easy to pretend audits aren't a problem until they're right there in front of you. So one of the things that I recommend our clients do as you're answering METs and not METs, as you're looking at data and choosing measures, is to talk to your consultant about if you were to be audited, what documentation would you have to have in place? This is a great way to improve workflows, improve documentation, maybe help some other projects going on in the office, and it creates a great safety net. In the event that you are selected for audit or CMS chooses to audit your practice or your submission, you would have at least had some consideration and some thought to what that might look like. The other thing that really happens in quarter two is we want to make sure that the assumptions we made in quarter one are what we want to go with. If you decide maybe you'd like to try a new measure in quarter one, quarter two is the time to decide this measure is great for us, or, oh, this actually isn't the measure we thought it would. So this is kind of your testing, your validations. We're double checking all of our assumptions and understandings. Quarter three, as far as the MIPS project might seem like you're just kind of coasting, but it is not. So in quarter three, as far as your current submission, you're probably just following through the workflows you already have, sending data at regular times. Maybe there are a few outstanding items for PI or other areas that you're kind of checking on. But as far as your current submission, it might seem like a mellower time. What we find is that in quarter three, CMS is really busy. That's when we get all their feedback reports from the previous year's submission. So there's a lot to look at. We can see how CMS scored you in the previous year. If you've had providers who received different scores from different places, we can see how you scored in the cost category, what that ends up looking like in terms of points. Does that create a vulnerability for your current submission? Have we mitigated that? It also is when the proposed rule comes out. So CMS publishes the proposed rule in quarter three. It is their statement of intention. It's what they say they would like to have happen as far as the rules of all QPP reporting programs in the coming year. This is a huge opportunity for every practice out there to decide and have their voice heard and decide how they want this program to go. The comment period of the proposed rule, I believe it's 60 days, and any comment that is made, the CMS team is required by law to review and respond to. So this is an opportunity for your voice to be heard. I know there are lots of challenges in the MIPS program, even with MVPs and APP. And it's really hard kind of when you're in the thick of it and, you're trying to run a practice, you have a lot going on. But commenting in the proposed rule is the way that you can say directly to CMS, here is how this program works for me or not. Here are the challenges I'm facing. Here's how I would like to see it be done differently. So I really recommend that, everybody, large health systems, medical societies, solo providers, support staff in the office, if you have ideas or concerns about how the program is working for you, for your providers and your patients, commenting in the proposed rule is a great way to have that concern or opinion heard. All of that happens in Q3. So Q3 can be quite busy in terms of, what's going on with CMS. They give us a lot of information there. So moving into quarter four, this is where we're kind of making all of those final end of the year decisions. If for some reason you need to apply for the extreme and uncontrollable circumstances hardship to have one or more of the categories not apply to you, quarter four is the time to do it. We also want to make sure that all of the processes and decisions that we have put in place over the year in terms of the project really are what we want to do. Lots of folks maybe start with 10 measures, and then by the end of the year, they've narrowed it down or they choose their best 6. Lots of folks might decide that they want to work on a traditional MIPS and an MVP throughout the year. And in the fourth quarter is really where they're making those decisions about which submission is going to be in their best interest, what is going to make the most sense for them and their practice. And we're just kind of tying up all of those loose decisions, those loose ends, so that in quarter 5, which is January of 2026 in this case, we're ready to make submission. The goal is that you have all the decisions made, all of those confirmations in place. Maybe you're waiting on, some last minute billing or some last minute paperwork, but in quarter 5, you're ready to go and you make that submission to CMS. And then we start all over again. We go through it all again, starting for 26 reporting.
Wow, that sounds like an awfully full year, Brigid. Thanks for that those insights. It sounds like to optimize things, a practice really has to start a year, 15 months before the submission is due. Does that mean you can't take practices late in the year?
Not at all. One of the things that we really pride ourselves on is meeting clients where they're at. We take practices all year round. New folks come to us at various points of the year. Really, we want you to jump in as you're able. Mingle Health has been around for a while. We've helped lots of folks with submissions, and we have some tricks up our sleeve. There are ways to minimize your reporting burden in year 1 so that in year 2, you're ready to really optimize and go for things that are important. There are also ways that we can kind of start halfway through the year and get caught up. Maybe start in quarter 3 and get caught up. So starting at the first of the year is the optimal option, and anytime you start is better than not starting at all. So anytime that you're able to reach out and get started, you're helping yourself and your submission be better. And then we get to start in quarter 1 the following year and hopefully improve your scores even more.
Great. That's comforting. What tips do you have for MIPS participants to get the greatest value from their Mingle Health client services consultants?
Oh, that's a great question. So I think probably my best advice for a practice working with Mingle Health is to make sure that you are engaged in the project. One of the things that can be really challenging is, maybe you are working with us all year and you weren't able to get us data until, September, October. That's okay. We can definitely still work with you. And certainly, we have missed out on some of the excellent value that our consultants deliver in terms of data validation and recommendations early in the year. So engaging early, engaging often, asking a lot of questions. Our consultants are experts. They know this program in and out. We have a wide bench of SMEs of all different categories, all the way up to MD on staff to help us understand the intentions of measures, understands the clinical nuances. So even if your consultant doesn't have information, we absolutely have the resources to get it. So the more questions that you ask and the more you're engaged in the project, the more the consultant is going to be able to help you be successful and meet whatever your goals are around the project.
That's helpful. And as you look over the clients you've assisted, what are the characteristics of a MIPS participant that seem to be predictive of higher scores?
Yeah, I think probably the biggest characteristic is engagement. There are lots of different reasons why a person may or may not have a high score. quite frankly, sometimes the design of the program gets in the way of specific folks getting a high score with no reflection on the quality of care they're doing. I will say, in most cases, engaging with us, being able to share information with us, allowing us to kind of talk you through things, consider lots of different options, and being able to navigate your own systems and the practices, needs, and focuses are going to be really helpful in allowing us to support you to a pathway that's going to get you the best score. Sometimes the program is just really challenging. We have specific specialties that don't have a wide variety of measures. We have some folks that only see and treat patients in very specific ways. They don't really have a lot of options with MIPS or MVP. So all of those components can be mitigated and navigated as long as we have some time and some engagement to work on them. So I would say folks who perform really well in terms of score are engaged, and they're continuing to work on the project year round. This isn't a kind of twice a year conversation. They're working on that continuous improvement and working on trying new things throughout the year.
Oh, great. You've been a wealth of information for MIPS. Let's take a different tack at the moment, because we've got that MVP program, the MIPS Value Pathways that Medicare has been bringing into the mix for the last few years. So with the release of the final rule for MVPs in 2025, what do you see as the most significant changes affecting the clients you and your team work with?
When it comes to MVPs, what we're really seeing in 25 is that CMS is really dedicated to this pathway, and they're really investing in the pathway. So they've added 6 new MVPs, which puts us at a total of 21 MVPs. And according to CMS estimates, about 80% of eligible clinicians would have eligibility for one MVP or another. So they're really trying to make sure that MVPs have a broad reach and that lots of different types of providers, in terms of credentials, specialty, location, patient population, et cetera, that lots of different types of providers can report an MVP successfully. They have done a little bit of simplification. So I don't know if folks are familiar with reporting MVPs in previous years. The practice or provider had to choose between 2 population health measures. They no longer have to. CMS will calculate your population health measures and apply the best score. So they've done a little bit of kind of administrative simplification in the MVP arena, trying to really make sure that it's available and accessible for all types of practices.
Thank you. Now, Medicare has been developing the MVP program in a stepwise manner. What is your understanding of the steps or milestones that we can expect from that program?
Yeah. So this level of stepwise development is very common with Medicare. We've seen it in lots of their different quality programs, even programs within the QPP. And we've seen that CMS really starts with the bar low. They want to give everybody a chance to get some practice, use a new measure or a new pathway with very little stakes. And then gradually they sort of increase the requirements so that they're actually being able to assess what is high quality and low cost care and what isn't. So in general, that's the same approach they're taking with MVPs. What we are expecting, and I do just want to put a fine point on this, until the final rule is finalized, everything we're discussing here is expectations. Nothing is written in stone yet. So what we are expecting to see is that in performance year 2026, subgroup reporting will be mandatory for those multi-specialty practices that report an MVP. In 2026, if you choose to not report an MVP, no problem. There's no subgroup requirement, there's no MVP requirement. But if you do choose to report an MVP in 2026 and you're a multi-specialty, you will be expected to use subgroups. So this is really the next step in CMS encouraging practices to participate in MVPs and to participate in MVPs in a meaningful and relevant way to how they're seeing and treating patients. We expect new MVPs every year. I know in 25, CMS estimates about 80% of their MIPS eligible clinicians are covered by an MVP. That's great. And we would want to see 100%, right? We want to see options. We want to make sure that MVPs are a available and accessible path for everyone. At some point in the future, they have not specified, CMS is anticipating that traditional MIPS would end and MVPs would be the process for MIPS participation. This, again, we have no time frame associated with this. And it would probably take some rulemaking, lots of further development of MVPs, lots of clarifications before we would be able to get to that point. But it is clear that that is the direction CMS wants to move. We can expect, as CMS works towards that goal of everyone doing MVPs and traditional MIPS not being an option, as they work towards that goal, we'll see more and more MVPs being available. We'll see higher expectations around MVPs, and we'll probably see some of the same simplifications that we've seen in 2025 with the administrative claims measures. CMS is really dedicated to making MVPs a great option for reporting for as many practices and providers as they can.
That makes a lot of sense. Now, as you look at the MVP program, why would a MIPS participant, or why should a MIPS participant consider using an MVP before they're required?
MVPs work really well for lots of practices and providers. For one reason, you only have to report on 4 quality measures as opposed to 6 under traditional MIPS. If you're a practice that struggles with measure selection or has a really challenging time accessing your data, if it takes a lot of manual intervention, doing it on 4 measures is going to be easier than doing it on 6. The other factor for MVPs that are really beneficial to practices is it's a great way to limit your exposure to the cost category. When you select an MVP to report, you know which cost measures could apply to you. So instead of having the full range of cost measures that may apply to you for a variety of reasons, maybe you feel a little overwhelmed or like you can't control that, through an MVP, you know exactly what cost measures could apply to you and can really focus on those areas, make sure that you are paying attention to those patients and impacting that cost score. Another great thing about MVPs is that for the improvement activities, you only have to report 1 improvement activity as opposed to traditional MIPS where you would have 2. And in the PI category, if you have the promoting interoperability category reweighted anyway, maybe you're a small practice or have some other special status, that still applies in MVP. There's no additional burden put in place by reporting MVP. So primarily the reason folks should consider an MVP is it really can make your reporting significantly easier. And it is a great way to reduce some of the burden and risk that practices can experience in the traditional MIPS program.
So, yeah, Brigid, that's a great discussion of MVPs, but it still leaves me, and I think a lot of our listeners and clients and prospects, it still leaves them confused. And there's 2 issues that I really haven't been satisfied with what I've heard from Medicare. Talk to us a minute about when Medicare requires MVPs. How do they define who can use a subgroup, or how will they? Do we know? And what do they do with providers who don't have an MVP that seems applicable to them?
Dr. Mingle, those are exactly the questions that come up when we talk about MVPs with clients. So to answer the first question of How does a practice know if they have to be a subgroup? How do they know if they're multi-specialty? The answer is we're not clear yet. We have obviously done a great deal of research. We've put in lots of tickets, and CMS has provided some information to help us understand how they're determining a multi-specialty practice, how they're trying to determine the difference between maybe what a physician has for a taxonomy as opposed to the type of care they're actually doing. It still isn't very well defined. What we are finding through tickets and support calls and questions into Medicare and their contractors is that it seems like there is an idea that a specialty or a multi-specialty practice would have different specialties clearly defined. So, for example, if you were a practice doing cancer care, maybe you have a hematology department or an imaging department and a palliative care department. What we are finding is lots of practices don't follow that clean and neat model when they're when they're multi-specialties. And even in the example of the cancer care, for example, you might have someone whose taxonomy is palliative care, but they're only working with cancer patients. And so advancing cancer care MVP would be very appropriate for the work they're doing, but may not match their taxonomy. CMS hasn't really clearly defined where the rules and lines are around that and how a practice or a vendor such as ourselves would be able to identify which MVPs are appropriate for which practices, providers, subgroups. So it's still very much being clarified and defined. What I do expect is with this 2026 timeframe kind of looming, either we will get a lot of clarification very soon in the next 9 months or so, or that timeframe might be kicked out a little bit as CMS kind of maybe gets some more resources available and has an opportunity to do some more education. The other question you brought up that I think is really interesting and important to address is what to do in the event that you are required to do an MVP, but no MVPs are available to you. Going back to this example of a cancer care center with a palliative care specialist, for example, there is no palliative care MVP at the moment. So in that instance, we're not really sure what CMS would expect from that palliative care provider. We're not exactly sure what they would have to do. Those are some of the ongoing kind of operation questions, I think, that hasn't fully been defined by CMS yet. They have a great idea with MVPs, and it makes a lot of sense. They want practices and providers to report on the type of care that they're doing so that patients can be healthier and costs can be lower. That absolutely makes sense to me. When we get into the nitty-gritty of how to do it, sometimes it takes a bit longer to sort out all the details and the rules and the pathways. And I think that's what we're seeing with MVPs. There's still some definitions and some resources that are needed from CMS. I expect we will get them. MVPs, I don't think, are going away. I don't think CMS is going to abandon the MVP idea. It's a great idea and works well in a lot of cases. But we definitely need some more clarification for practices to be able to be compliant with the regulations and still meet the goal of the program, which is reporting on patients and care that they themselves are giving. So it remains to be seen is the short answer.
Yes, I can see that, Brigid. I think what you're describing is a situation where we should be especially vigilant in the rulemaking cycle with the next couple of proposed rules. It could be critical to keep an eye on what they're proposing for these two issues. And to comment liberally on that to help guide it to something that makes sense.
Absolutely. Every practice and provider probably will need to report MVPs at some point. And so being very mindful of the requirements and the rules and the nuances of those rules as they're being formed can really help all of us set MVP up to a pathway that's going to work. That means reading that proposed rule, making comments on how a proposed legislation, or excuse me, how a proposed process would work for your practice or not work. And you all have great ideas. You know what it's like to see and treat patients and have to interact with these sort of quality reporting programs. Commenting on the proposed rule is a perfect way to let CMS know how you think this program would work best for you and your patients. So absolutely, we all need to pay very close attention and make comments on the proposed rule. That's the best way to make sure that we have the programs that work for us.
Thanks, Brigid. That makes a lot of sense. So let's move our attention to the APP, that is the APM Performance Pathway, particularly how it pertains to Medicare Shared Savings Program. With the release of the final rule for the Medicare Shared Savings Program 2025, what do you see as the most significant changes affecting the MSSP clients that you and your team work with?
MSSP has some changes coming, that's absolutely for sure. So originally, CMS had proposed to sunset MIPS CQM reporting in 25. They have postponed that for at least 2 years. So there is still some time for APP submissions to be made using the MIPS CQMs. Particularly for those MSSP folks, they have finalized the APP Plus measure set. So the APP Plus measure set are the measures that we know and love: diabetes, depression screenings, blood pressure management, and they're adding additional measures in, but they're doing it very slowly. So they're adding one measure a year at the moment. So in 2025, the breast cancer screening measure has been added in for MSSP ACOs to report. Moving into 26, we expect to see colorectal cancer screening. 27, substance use disorder identification. That's the measure for adding into 2027. And then in 2028, they are anticipating doing the screening for social drivers of health and adult immunizations. 2028 or later. Again, we'll watch those rules and see how this is rolled out.
Great. Now, we talked about an annual rhythm to MIPS reporting. What do you see as are there any differences in that when you're thinking about the APP Plus?
Absolutely. So the key difference is just in the amount of time. When we talk about MIPS, we're usually talking about one, maybe 2 or 3 practices. We're talking about maybe a handful of locations, probably on similar, if not the same systems. When we're talking about APP reporting, the volume is just increased. So the steps are primarily the same. We'll start by identifying what the goals are, what the ACO or their participants are interested in achieving, how they want to achieve it. And then we get data and we start data validations. We make sure we are all on the same page as far as what data is needed, what it means. We look at scoring. All the steps are the same. The time frame is significantly longer. For a MIPS client, we're talking about probably a 15-month year. That's the cycle. For an APP client, we're probably looking at 2 years to have the optimal results. That data validation piece always takes longer than we all anticipate. Getting systems connected to each other and getting all the information back and forth is challenging for one instance, but if you multiply it by 40 or 50 or 100, the challenge only grows that much larger.
Got it. Now, does that mean that An ACO shouldn't even bother to sign up. They don't have 2 years to work with.
Not at all. Very similar to MIPS. The speed of the project really depends on how you are able to engage with us. There are definitely ACO practices that are able to engage very quickly, and the data comes through. We all do our validation and feel confident, and we're able to move forward in a shortened time frame. Again, just like with MIPS, those might be good results. They may not be your optimal results. The important thing to remember is starting with good and reaching towards optimum is the pathway. If we wait till we can do it perfect, oftentimes we're waiting forever.
All right. So I think you're saying again, it's better to start now than never. But the more time you give it, the better your results are going to be.
Absolutely.
I can see a lot of parallels between the MIPS, the MVP, and the APP or the APP Plus submission or data collection and submission process. How do you find that the typical APP MSSP participant, that is the APM Performance Pathway for Medicare Shared Savings Program, how does your service to those programs differ from the MIPS?
Yeah, that's a great question. So when we work with practice to report MIPS, we're working directly with the practice and sometimes directly with the provider themselves. When we're working with someone doing APP or APP Plus, for example, we're not working directly with the practice, we're working with the ACO. So the ACO entity has support staff. They have lots of folks who are very knowledgeable. And so our role at Mingle Health is to be that technical support to keep the ACO updated on regulatory changes or clarifications, to process their data and kind of address any technical issues that may be in place. But really, our role at Mingle Health is to support the ACO, who is in turn supporting their practices. There definitely are some times that an ACO might find, or maybe they know off the bat, that they don't have the staff or the expertise that would be needed to support the practices themselves. And we're definitely available to help if that's a need that the ACO has. But in general, what we find is that Mingle Health gets to be behind the scenes and really help the ACO be their best selves, help them to be knowledgeable and support their practices the best way possible, while we can kind of be the engine behind the scenes.
But then I'm to understand that if they find that's not the case, you can expand your service and reach out directly to the individual practices.
Absolutely. So, one of the important things is that we're able to meet folks where they're at. So, if the ACO starts working with us and thinks their need is one thing, but they discover other things, we can be flexible. We're happy to add additional support, additional services. We're happy to, rethink the way we work together if the needs change. And so we have a product in place to support that. We want to make sure that the ACO and the practices are successful. And what that looks like can be a little different for everyone.
So pulling it all together for the MSSP doing the APP Plus, what are the characteristics your team sees today of MSSP clients who excel in the APM reporting process?
Yeah, it's not that different actually from the MIPS folks who excel. It really comes down to engagement. With MSSP folks, the more understanding that the ACO has and the more connection that the ACO has with some of their practices, occasionally that can make a big difference. But in general, if the ACOs are engaged and working, following the steps, working towards the next goal, they're going to be successful. There are, of course, some unique barriers in the APP ACO landscape. Oftentimes, the ACO doesn't necessarily own the data that the practices have. So, the more time that a APP or an ACO would have to cultivate a relationship and gain those accesses, the better. That being said, in general, if you are engaged and continuing to work towards your goals in the project, you're going to be successful and you're going to see progress.
Thank you. That makes a lot of sense. Brigid, thanks for joining us for these special questions about the QPP 2025. And thank you, everyone, for joining in.